There are other reasons why people self-injure. Now, people often say, isn't it attention seeking? I mean, I remember a kid who'd been self-injuring for 2 years, and the parent said, I think it's attention seeking. And I asked the parent when they found out, and they said, oh, we found out last week. I said, well, that's terrible attention seeking if it took you 2 years to find out that the person's doing it. It almost never is attention seeking, even though many people consider it attention seeking behavior. Now, it is a statement that says, I'm suffering.
Welcome back to Shrinking It Down, Mental Health Made Simple. I'm Gene Beresin.
And I'm Khadijah Booth-Watkins.
We're two child and adolescent psychiatrists at the Clay Center for Young Healthy Minds at the Massachusetts General Hospital. Today we have a special guest joining us to help us unpack a difficult topic, self-harm in teenagers. Dr. Blaise Aguirre is a child and adolescent psychiatrist at McLean Hospital and assistant professor of psychiatry at Harvard Medical School. Dr. Aguirre is also the founding medical director of the 3 East Continuum of Care, a variety of programs for teens that uses dialectical behavior therapy, or DBT, to target self-endangering behaviors as well as the symptoms of borderline personality disorder traits. So, Blaise, thanks for joining us. We're glad to have you with us.
Yeah, you're welcome. Thank you for having me on. And I know I work on a DBT unit, but nevertheless, we're seeing even more demand for ideas to address self-injury.
And I hear you have jokes.
Gene, I have jokes. They tend to pop up as things go along. So if the time shows up, I'll say it when it comes. They tend to embarrass my children. So I come to work and I try to tell them there, and they embarrass my staff as well. We'll see.
We might need a joke or two when we're talking about self-harm, because sometimes you have to offset something that's so scary and potentially dangerous that we may have to offset that. But okay, let's get started. So for our listeners who may not know, can you tell us what self-harm is and why some teens do it?
Mm-hmm. Mm-hmm. Yeah, so very broadly speaking, self-harm is the way that most people think about it, let's put it that way, is sort of any self-destructive act that is where skin or body tissues are injured without the intention of suicide. So the types of things that we see are cutting. That's the most common. But then we see things like people burning themselves, people punching walls, people banging their heads. Those are the most common types of self-harm that we see. And, we opened up our unit about 15 years ago with the explicit intention of helping people who are suicidal and who are self-harming. But so the most common type of self-harm, of course, is as I say, the cutting, the burning, punching walls, and head banging.
And so most of the time when we think about self-harm, we do think about the harm that people do to themselves that leaves these scars. And sometimes the scars aren't so obvious. So are there other ways in which young people can engage in self-harm that is a little bit different from cutting, but still self-destructive?
Yeah, I mean, people have tried to think about this in different ways. So for instance, is restricting eating a way of harming yourself? Is using certain drugs a way of harming yourself? Is getting multiple piercings and tattooing ways of harming yourself? Is getting into a dangerous sexual encounter with an unknown person a way of self-harming? So the way that we think about these behaviors, where there's potentially damage to the self, is what we call the function of the behavior. Like, why is the person actually doing that behavior, and how could it potentially be destructive? So there are other forms of self-harm, and when we see these other forms, we really want to, as I say, understand the function. But what I mean by the function is the reason why the person is doing it. Because somebody might want to have a drink of wine, a glass of wine, just because they want to have a glass of wine. But others might do it because they want to change how they're feeling. So we really look at the intention and the function of the behavior.
So I have a number of questions. So it's self-harm. So self-harm, as you're defining it, is not necessarily suicidal?
The vast majority of self-harm, I don't know, it would be 99.99% of the times that it happens is not suicidal behavior. Now, a couple of things about this. It is not suicidal behavior. However, there can be self-harm with suicidal intent. The other thing is, if there's self-harm through cutting, there can be a lot of blood, and that can be very scary to families. And then they can jump to the idea or the conclusion that the person is trying to complete suicide or to kill themselves. And we also know that even though it's a different concept, that people who self-harm are somewhere, depending on the research study, between 30 and 60 times more likely to complete suicide. So it's not the same thing, and yet it's highly, we look at it because the two things are highly connected.
So it's a warning sign. You mentioned reasons, and I've heard of a number. I've heard of it, for example, as help-seeking behavior, as tension release. So I've heard it being planned, and I've heard it being impulsive. So could you elaborate on some of those reasons and situations? Is it generally impulsive or planned, and what some of the reasons might be?
Yeah, I mean, certainly with adolescents that we see coming to dialectical behavior therapy, the main reason that we see is as a way of reducing very intense and powerfully painful emotions. Now, for those of us in the field, those of us who are maybe more sensitive than people in other professions, we feel things deeply, and we can feel things pretty intensely. But imagine feeling so much that the feeling becomes painful, and that cutting yourself actually feels better, so to speak, than experiencing the intense emotions. And so we know that there are brain changes that happen when somebody self-injures through cutting. And those brain changes, so some people think it's because of the opiate system in the brain, that there's a chemical release of endogenous endorphins, meaning the opiates that the brain makes, and that soothes the brain, or that it distracts the person from emotional suffering to sort of physical suffering. But nevertheless, the main reason is that whatever is going on for the person is intolerable and it's unbearable, and that cutting provides some answers and provides temporary relief. There are other reasons why people self-injure. Now, people often say, isn't it attention seeking? I mean, I remember a kid who'd been self-injuring for 2 years, and the parent said, I think it's attention seeking. And I asked the parent when they found out, and they said, oh, we found out last week. I said, well, that's terrible attention seeking if it took you 2 years to find out that the person's doing it. It almost never is attention seeking, even though many people consider it attention seeking behavior. Now, it is a statement that says, I'm suffering, and that by self-injuring, they feel something, they feel alive. And we sometimes have young people tell us that they're really bad people, that they loathe themselves, they don't like themselves, that they're not that their lives aren't worth anything, that they deserve to be punished, and so they'll see it as self-punishment. We do see self-injury in other groups, although we don't tend to see them on our program. So, for instance, some people with developmental disabilities might do things like bang their heads, and then the treatment of that would be slightly different. And then there's this other form of self-injury, which we see a couple of times a year, and this tends to happen more in people who've got very significant post-traumatic stress disorder, and where they do things like they cut themselves open a little bit and then put foreign objects into the cut. So sort of like an insertion of a foreign body into a cut. It sort of keeps the cut open and weeping, or they swallow foreign objects like paper clips and things like that. Those are different types of self-injury, but again, the most common one that we see is cutting of the self. Now, one thing you asked earlier about whether the planned one versus the impulsive one. One of the things that we do see in some people who've got obsessive compulsive disorder, they're cutting. And I've seen it in some of the patients that we see, tends to be a little bit more planned. It's more predictable. It's less erratic. For many of the young people we see on our unit, where it's very emotionally driven, it can be unpredictable because and very dependent on the person's mood. So something bad happens and then they self-injure, or someone doesn't give them a call and then they self-injure. So you do want to look at the form of the self-injury. It's very important.
A couple follow-up things to that, Blaise, and that is that this might be a kind of a psychoanalytic or a psychodynamic reason, but I've seen a number of folks who've cut to attack, a parent or some person close to them that they've internalized, so that they're not really attacking themselves, they're attacking someone else. And I wonder, I know that's not part of DBT, mm-hmm. but it is a more classical mm-hmm. version of cutting. Mm-hmm. And the second comment is that I've heard from many of the folks that I've seen cut that the cutting doesn't hurt. For some reason, it doesn't hurt until later, until they feel the blood on their leg that's cold, or until they feel the wound. So, two questions. Are they cutting what we would call an introject, or somebody that they've taken in? And the second one is, what do you make of this business about numbness and then feeling it later?
Yeah. So there's actually, I remember very early on, I had a kid who had who did a lot of cutting. We went out on a pass and was running, slipped and cut themselves. And they were in tremendous amount of pain, and they went to the emergency room, and the physician said, "How can you be in pain? You cut yourself all the time, and now you got cut, and now you're hurting." So what research seems to show is that in the brain that is highly emotional, self-injury, actually, the impact of the cutting isn't felt in the moment. There's actually been tests where people had, they're called pressure tests, or you increase the amount of pressure on a person's hand and to the point where they, or maybe temperature to the point where the person feels pain. And people who have emotional dysregulation disorders like borderline personality disorder tend not to feel the pain until much after. So people with high emotionality don't experience the pain. But there's something about tissue damage that leads to the release of chemicals that soothes the brain and calms it down. Later on, once they're calm, then they're like everybody else, they can begin to feel the pain. But the truth of the matter is, in the moment, it's actually soothing. And if you think about this, I was trying to think about an equivalent in people who don't self-injure. But if you get bitten by a mosquito, and then you're very itchy and you scratch yourself, how soothing that feels. It's sending messages to your brain and that scratching can be pretty significant. I mean, to the point of tissue damage, but that's causing release of chemicals in the brain that just sort of soothes the brain. Now, the old psychodynamic idea of punishing another, we have seen it on rare occasion. But one of the things that we do in the work that we do, dialectical behavior therapy, is to be very explicit and very upfront about the conflict that exists between, say, parent and child, and then find other mechanisms to be able to deal with it. So in my, I was trained psychoanalytically. I would have spent a long time kind of exploring that behavior as aggression towards a parent, right? In DBT, we say, look, we don't want you to be sort of scarred up. It's clear that you're angry at your parent for the things that they've done or the perceived things that they've done. How are we going to do this differently? So we get on top of it as quickly as we can, whatever the reason is for doing so.
So one of the things that we often do, I think, in the field is we talk about how people present and what their risk factors are, and we omit the uniquenesses of, if that's a word, of these various groups and the uniqueness of their experiences in terms of whether they've had trauma, whether they've been predisposed to a lot of violence. So I guess I'm curious to know if there are any differences that you see or that is known about in the literature as it relates to the motivation or the function of the behavior in some of the various groups. I guess even if we just think about, boys versus girls, or, we think about LGBTQIA, are there differences in how they present or how they are motivated to engage in this behavior?
Mm-hmm. Yeah. So initially, when we first started the program, it was a very binary group. It was actually, in the very early days, we only treated girls, young women, and then we opened up our program to boys and girls, and then we opened up our program to people who were not binary, who did not identify as male or female, gender fluid, and then to people of all faiths, of different ethnic backgrounds, racial backgrounds, etc. And so over time, we've evolved a better understanding of the various groups. One of the things that we see is that, and again, this research is changing. So, but as of today, that women tend to girls, people who identify as women, tend to self-injure more than boys. Then we also know that people who are LGBTQ, especially trans people, tend to self-injure much more than almost any group. We're also seeing an increase, even though it's not as high, self-injury in African Americans or certainly Black Americans. We're seeing an increase. But the reason why the various groups self-injure or don't self-injure, for instance, I've had people who are devoutly faithful in their faith, whether it's Islam, Christianity, Judaism, who will not self-injure, not because they don't want to, but they won't cut because of markings on their body, so that there's something about their faith that is not allowed within their faith, but maybe they will self-injure through restricting or something like that. The reason, especially the gender non-conforming or gender different people self-injure often has to do with a lot of the social response to who they are. So I mean, we know that trans people, for example, are much more likely to be bullied than other people, and so that bullying can lead to such an aversive state of experience that they self-injure for that reason. The the other thing is that girls tend to self-injure younger. What we've seen is that girls have maybe more cuts or more cutting episodes, and then when the boys have cut themselves, it tends to be. I mean, I've seen more stitches, for example, more in boys than in girls. So so there are differences. I mean, we use similar kinds of treatments, but some of the reasons have to do with something that's going on inside of the person themselves. Interpersonal reasons, and for some people, it's interpersonal reasons, stuff going on in their communities, in their schools, in their societies. So,
I want to follow up on something you said, because
yeah.
I think one of the things that we often hear a lot, and it's hard to kind of reconcile what to do with that information, is when people have the urge to self-injure, but they're not. And so you mentioned that some people won't do it because of scars, and some people have, I guess, maybe become a little bit more aware or a little bit more in control of their impulses, and so they don't, but they still have strong urges. How do you think about the urges minus the act?
Yeah. This can also be a very, very confusing question for parents, because what happens is, first of all, just the idea of cutting yourself is in and of itself very complicated. But then, even if you have the urge to do something, do you need to act on it? Now, if we remember that adolescence is also a time of exploration, and young people tend to be riskier and they tend to be more impulsive. You can have an urge and behave on that urge, or you can have an urge and not behave on that urge. People can have an urge to smoke and not smoke, or people can have an urge to eat a second donut and then not eat that second donut. So an urge is just this phenomena, a behavior that just happens in the brain in terms of like, okay, this is the thing that I want to do. Now, people early on in treatment, their ability to override that urge is pretty impaired. They don't have the skill set to be able to do it. And what we want to do is we want people to be able to notice that urge, and then not act on the urge, and instead act on a different behavior. Overcoming those urges can be really, really difficult. I sometimes do a practice with parents where I say, okay, I want you to sit with your mouth closed for 5 minutes, and I want you to notice the urge to swallow and not swallow. And it's remarkable, because there comes a point at which you feel like, I have to swallow. There's nothing I can do. I have to swallow or do something else. So overriding urges is actually very difficult if you don't have alternatives. Some young people expend a tremendous amount of psychic energy overriding the urge if they don't have the skill set to be able to distract from the urge to do something. The other thing that we know is that over the course of a day, people become more exhausted. All of us do, whether we have a psychiatric disorder, mental health illness, or not, a psychiatric disorder or not. And so we tend to see a lot more self-injury in the evening. So even though they're able to override the urge to self-injure during the day, they're not able to at night. And then there's other things. So for instance, in some people who've got obsessive compulsive disorder, sometimes they have what we would call respondent behavior. So they see a knife, for example, and they self-injure because they respond to the knife. So the knife prompts the self-injury behavior. And the people that we treat typically with emotional dysregulation disorders wouldn't be doing that if they were feeling okay.
So Blaise, one other question. Are there certain other predispositions that might make one more likely to engage in self-harm? I mean, you talked about borderline personality disorder, and obsessive compulsive disorder, but what about other mental health disorders?
Yeah.
And also, besides the psychiatric disorders, what family dynamics or family history might make it more likely that someone is going to be a cutter or engaged in self-harming behavior?
Yeah. Well, I mean, definitely, we see, self-injury is not the domain of borderline personality disorder, nor vice versa. And in all mental health conditions, we see self-injury. And in most cases, when we see self-injury, it is an attempt to change the inner state of the person. Certainly, developmental disorders as well. We see sort of self-injury. In schools, being bullied and bullying others can lead to self-injury independent of mental illness. Again, struggling with low self-esteem, feelings of worthlessness, people who are unable to make or maintain relationships can self-injure. In terms of family dynamics, I've seen young people with very sort of goal-oriented, very driven families where maybe, two kids have gone to Ivy League schools and then the youngest one or one of the other ones just, is not academically prone or is interested in arts and everything and sort of feels that very pressured to excel in the way that their siblings and maybe their parents have. And then they don't, if they don't succeed in those ways, they'll feel that they're not part of the family or they're less than. And I've seen self-injury in that kind of context. I've seen kids who've got learning difficulties, learning disabilities, self-injure. Actually, one thing that surprised me is kids with autism or on the autism spectrum self-injuring. But again, certainly we talked about LGB. I've had kids who've experienced either the traumatic loss or just the loss of a loved one self-injure. So, like the unbearable grief of having lost a beloved relative, a grandparent. I had a kid who reached out, who started self-injuring after the loss of their beloved pet. So, the theme of loss, the theme of lack of connection, the theme of rejection, within the presence or not in the presence of mental illness is one of the reasons why people self-injure.
If it's safe to say that self-injury is a maladaptive coping skill, there are theories that say taking this act or this skill or this behavior away from someone is actually causing more harm and can be dangerous. Is that true? Does self-injury serve some sort of psychological or defensive protective purpose for young people?
And I'm glad that you used the term maladaptive coping skill, because, people say, well, why are you doing these ineffective behaviors? And in fact, they're very effective. You see, this is the thing that a lot of people don't understand. They're highly effective, but to your point, they're maladaptive in the sense of like that it's not a behavior that is generalizable or that you can transport, or one day if you want to have a family yourself that you're going to say, okay, look, I've had it with you guys, I'm going to self-injure. Now, so the way that dialectical behavior therapy, the therapy that I do, thinks about this is a person is going to continue to do any behavior that works for them. So if self-injury works for you, even if it's maladaptive, if it reduces your tension, if it helps you feel better in the moment, you're going to continue to do that behavior. Simply taking a behavior away from someone is not successful. We haven't found a way to do that. You can't just simply take a behavior away. You have to replace it with something that's maybe less effective in the short run, but is more adaptive in the long run. So we see kids who self-injure as having a deficit, a skills deficit in their ability to regulate their emotions and regulate their relationships. And so we're saying, okay, you're having a difficult time regulating your emotions and relationships, you've developed a skill, which is to self-injure as a way of regulating how you feel in the moment. The problem is it's very short-lived and it doesn't last very long, and you have to do it repeatedly. So we're going to teach you other mechanisms, other methods of doing it. So if somebody were to say to me, if you just take self-injury away, is that a bad thing? What I've heard from some kids, what some kids have told me is that if they feel the way that they feel and somebody just took cutting away from them, that the likelihood of suicide would increase for them, without knowing other ways to deal with it. So it just doesn't work just taking it away. But also, I don't know how you would take self-injury away, because young people, or actually anybody, can find ways to self-injure even if you think that you've taken things away. So some people just remove knives from the house, but there are infinite objects to sort of self-injure with, if that's your goal.
And sometimes as caregivers and parents, we don't know if sometimes what our young people are struggling with is just a phase and it'll pass, or if it's something more serious. Do kids or teenagers grow out of this, or does it continue throughout their life, or does it actually kind of grow into something bigger? Do they engage in other kind of more riskier behaviors?
So what we tend to see is that it tends to peak around 19, 20, 21. So where we see a sudden bump around puberty. So younger in girls, so maybe 13, 14 in girls, and maybe 15, 16 in boys. And again, I'm using a binary system, but for the sake of this discussion. And then there is a little bit of dropping off, and then we see another increase around age 19 for both boys and girls. And that probably has to do with graduating from high school, going off to college, getting a job, leaving home, and those sorts of things. But then it definitely tends to drop off in young adulthood. So there's something about early and late adolescence that seems to predispose people to self-injure.
And so there's a question from a parent.
Mm-hmm.
So what do you feel about this idea of just letting them go through the process, even if it's long and slow? And how do you, as a parent, deal with, I guess, witnessing your child or your young person, engage in self-harm?
Yeah. Well, by the way, so it's a really important question. First of all, I would really work with the kid about reducing self-harm for a couple of reasons. One is we know that people who self-harm are more likely to die by suicide, even if the self-injury isn't suicidal in intent. There are scars that can happen, and that they can live with those for the rest of their lives. That without as long as they continue to self-injure, they're not learning other coping mechanisms, which are going to be critical for many sort of situations in their life. And I think that this is, as a parent who's seeing their child suffer, our therapy, dialectical behavior therapy, involves the parent and the child, so that it teaches the child what to do when they want to self-injure, and it teaches the parent how to react and how not to react when a child is self-injuring, and seeing it as a behavior of distress. So I think that the parent ought not to be suffering in silence, because the other thing that happens is that a lot of these kids are highly sensitive. So even if the parent is showing a very kind of stoic face, children can read right through that. Highly sensitive kids can read right through it. So I think that the parent ought to be getting help themselves, whether it's skills, whether it's their own therapy, to be able to deal with it. But I would 100% be bringing this up with kids all the time and saying, we have to find a different way. There are different ways.
So how do you treat self-harm? I mean, it's a great question. I mean, does it depend on, you mentioned reasons that one thing that I wonder if you address. Does it depend on the age group? Are medications useful? Is group therapy useful? I mean, I've heard this from a number of people. They wonder, okay, so what actually goes into the treatment process?
Mm-hmm. Yeah. Well, first of all, again, I think where many of us as mental health experts sometimes don't do our patients a service is understanding what I would call, what DBT calls, the function of the behavior. So in other words, okay, let's just say that a person self-injures because they've got obsessive compulsive disorder, and that the purpose of cutting is to satisfy a compulsion. Then you would be doing a treatment such as exposure and response prevention. I've had kids who've told me that they're addicted to cutting. And what we see in those kids is not only do they cut, but they cut longer, deeper, more extremely. And in those situations, if it's very clear that there's an addiction component, medications such as naltrexone can help those kids with the reason why they're cutting. We've had kids who've come in who tell us that the voices tell them to cut, so that the reason for the self-injury is a psychotic process, and that the function is to appease the voices. And so in that case, antipsychotic medication might be useful. For the kids that we see, it's for self-injury, and it's because they don't have other skills to be able to manage the self-injury, the emotional dysregulation. And in those cases, we haven't found that antipsychotics or naltrexone or ERP work, and then we use dialectical behavior therapy, where we teach skills to tolerate distress, to regulate emotions that are more adaptive. But it's hard to, so there's not a one size fits all, for self-injury. If there are developmental disorders, it might be preventative. So I think really understanding the function and the cause of the self-injury is critical to this.
So just thinking about how scary it must be when you discover that your young person is engaging in self-injury. And you spoke a little bit to what parents could do if they discovered their child is self-injuring. What are some things that we should not do as parents and caregivers?
Yeah. I was giving a talk the other day on sort of myths about suicide, and there's also some myths about self-injury. Simply talking to your kid is not going to increase the behavior. So, so what we want to do is we want to have a discussion with our kids about the behaviors that they're doing, whatever the behavior is. So if it's self-injury, then talking about self-injury. If it's suicide, talking to your kid about suicide. That talking about it is not going to increase the behavior. Now, remember, people do behaviors because they work for something. And so we have to think about what is keeping this behavior going. One thing that is sometimes parents have very, very big displays of their own emotions, like, what the heck do you think you're doing? Don't you realize how terrible this is? The parents themselves freak out. They show tremendous fear. Remember that many of the young people who self-injure are highly, highly sensitive. They're almost like emotional sponges. And so, having these big displays of emotionality isn't actually that helpful for these kids. And so, remember, children who are very sensitive will, when you show big displays of emotionality, will have their own big displays of emotionality. So you can dysregulate, but you can also co-regulate. So finding a way to be calm, not, waiting for a time to have a discussion about this is going to be really, really important. I also think that parents need to know a lot more psychoeducation on self-injury, just sort of understand it a little bit more. You can read about it, understand that it's often helpful in regulating emotions and regulating relationships, and that it's not about suicide. And of course, you have to always take it seriously, but it's it's getting away from some of the myths of self-injury.
Let me just ask one final question.
Mm-hmm.
We've seen psychiatric disorders in teens: anxiety, depression, loneliness, stress, which isn't a disorder, but they're stressed out, and suicidal behavior increase over the last at least 10 to 15 years. Have you seen cutting increase? I mean, you've been doing this a long time. Have you seen cutting increase over the last, say, 10 to 15 years? And if so, do you think that there's some societal issues or increased pressures on kids that we need to deal with, not just in DBT, but in kind of looking at our social environment and what stresses and pressures society is placing on the kids to foster maladaptive behavior?
Mm-hmm. Yeah, I think this is such a important question, because I think it speaks to the heart of the problem. When kids go to school, schools insist and parents insist on academic excellence and academic performance. And one of the things that we do is many schools have physical education and physical wellness. But one of the things that we don't do as schools is we don't have mental wellness and mental education. And the push for excellence, the pressure on these kids to do so well, is actually taking a toll. There was a very interesting paper called the Silicon Valley Suicides, where kids in Silicon Valley who were off the charts in terms of standardized tests were making suicide attempts and completing suicide at twice the rate of kids in other schools. I also think about kind of experiences of despair, whether it's substance use, etc. That we're waiting until kids are really struggling before teaching the skill sets that they need to be able to function. And I honestly would give up some of the things that we teach in schools. And maybe I would say, okay, math teachers, history teachers, English teachers, everybody has to give up a couple of lessons a year. Not worry so much on that final result and what they've learned, because and really focus on from very, very early on teaching the skills to these kids. Because the other thing is this: the less stressed a child is, the more they're going to be able to learn. The more stressed they are, the less they can retain memory, the less information they keep, the less they can learn. So it's, in the short term, we insist on academic excellence, but it's at a tremendous cost to the kids that we see. And then the other thing is the bullying that happens in things like social media is so much more powerful than what used to be face-to-face bullying, in the sense that bullying can spread very, very quickly, and people can be very ostracized very quickly on social media, and they've got no way of sort of defending themselves or making their case. So kids today are facing unimaginable stressors. Global warming, kids talk to me about that. Politics, racism, the war, Ukraine, Russia. They talk about these things a lot. They have access to the information, but they don't know, how to contextualize it and to manage it. And that's why I really think that we have to start at very young, in the same way that we teach kids academics and physical education, is teaching them mental wellness and mental education.
Well, this has been great. Really tough topic, and I really appreciate all of your information. I'm sure that parents and all caregivers are going to be very interested in what you've said. So the way we like to end is there something you're looking forward to over the next week or so, Blaise?
Over the last couple of weeks, I've done more teaching. I love teaching. I love thinking about difficult puzzles in mental health. But one of the really sort of exciting things for me is I've co-written a new book with a colleague for people who've got both borderline personality disorder or emotional dysregulation and obsessive compulsive disorder, and using a combination of dialectical behavior therapy and exposure and response prevention. A colleague of mine, John Hirschfield, and it's being submitted now for final putting together at our publisher. So it's just very exciting because it's been a particularly complicated group of young people to treat. So I think we're down to the last week waiting for our foreword. So yeah.
Congratulations.
Thank you.
Khadijah, how about you?
Yeah, that's super exciting because I think to your point in the very end, like it's really all about education for the parents and teachers, education for us as providers. So for me, what am I looking forward to? I'm just looking forward to relaxing. The fall has been so busy and not in a bad way, in a good way. And I'm also tired. So I'm looking forward to just relaxing a little bit and thinking about my family, hopefully being able to come together in a couple of weeks and what big fun we'll do with all of the nieces and nephews. So that's really what I'm looking forward to. So what about you, Gene?
Well, let's see. Now that gardening season is over, which has taken up a lot of my time, I'm looking forward to having more time to to play the piano and guitar. Because I've often gone into my lessons unprepared and I always feel terrible if I'm unprepared. So I'm looking to play more. So don't forget, everybody, that episodes will be airing every third Thursday of the month. Please subscribe if you're feeling generous, write us a review. We hope that our conversation will help you have yours. I'm Gene Beresin.
And I'm Khadijah Bush-Watkins. Thank you.
So I went to my ATM the other day, and I decided to stand in tree pose, like on one leg, in front of the ATM machine. And this person behind me got really, really annoyed. And they tapped me on the shoulder and said, "Hey, what you doing?" And I said, "Hey, why are you bothering me? I'm checking my balance." Okay, Khadijah, you know what? I'll tell you why you can't work on our unit. Because you just did the eye roll that everybody does on my unit,
Oh, so I'm perfect for your unit.
Well,
I
no,
would fit
because I've
right
had
in.
it's
Wait,
reinforcing as I keep going.
I thought this was a dad joke.
Oh, I have so many. I mean, we could, be laughing all day.